Good morning and good afternoon, everyone. Welcome and thank you for participating in this ISMP webinar entitled Designing Reliable Practices for IV Push Medication Use, a focus on safe administration. My name is Dennis Killian, and I currently serve as the Director of Pharmacy Services at Peninsula Regional Medical Center in Salisbury, Maryland. I will serve as the moderator for today's program. Before we begin, I'd like to take a few moments to introduce you to the faculty for today's program. Our first speaker is Michelle Mandrick. Michelle is the Director of Consulting Services at the Institute for Safe Medication Practices, ISMP. Michelle has over 20 years of experience in acute care nursing with expertise in perinatal and pediatric services, as well as executive leadership roles. In her present position, Michelle manages ISMP's consulting services, as well as performs on-site medication risk assessments and root cause analysis for healthcare facilities throughout the United States. She has frequently participated in the analysis of medication safety issues specific to pediatric and neonatal populations. Michelle leads ISMP's practitioner in residence and international mentorship programs and is currently leading the development of safe practice guidelines for the use of smart infusion pumps. She regularly provides educational offerings related to medication safety issues in the United States and internationally. Michelle serves as part-time faculty at Temple University School of Pharmacy. She received her BSN from Thomas Jefferson University and her MSN from Drexel University, and she is a member of Sigma Theta Tau International Honor Society of Nursing. For our second speaker is Susan Paparella. Susan currently serves as Vice President at ISMP. She is an experienced nurse leader in critical care and emergency services, and as Director of Quality and Risk Management. Susan brings extensive knowledge, practical experience, and a nursing perspective to the evaluation of patient safety issues. In her current role at ISMP, she is responsible for the development and implementation of a variety of professional and educational services, including the Medication Safety Intensive Program, which has trained more than 1,000 medication safety leaders since 2008. Susan organizes national summits designed to address complex medication safety issues and has led teams in the development and revision of a number of ISMP's safe practice guidelines. During consulting engagements, she assists organizations in the assessment of their medication use systems and implementation of changes to support safe practice. Susan serves as an adjunct faculty member for the Temple University School of Pharmacy and regularly lectures for practitioners across the United States and abroad. For 15 years, Susan has been the author and section editor for a column entitled The Danger Zone in the Journal of Emergency Nursing. Susan received her degrees from Villanova University. She's a member of the American Association of Hospital Risk Managers, as well as the American College of Healthcare Executives and Sigma Theta Tau International. For today's section, we have 4 objectives that the faculty will cover. The first is to recognize unsafe practices and at-risk behaviors associated with the preparation of IV push medications to adults. The second objective is to identify unsafe practices and at-risk behaviors associated with the administration of IV push medications to adults. Third, to discuss best practice and related error reduction strategies identified in ISMP's safe practice guidelines for adult IV push medications. And then lastly, the faculty will cover to employ the proposed gap analysis tool to assess current organizational practice for IV push medication use and define steps towards safer care. If you would like a copy of this presentation, you can access it under the Handout tab on the GoToWebinar portal. Each of our speakers will present about 20 to 25 minutes, and at the end of their presentations, we'll have 10 minutes for questions from the audience. To submit a question, you can do so on your computer. So there's a tab marked Questions on the GoToWebinar portal, and you can simply type your question there. You can type your question at any point during the presentation and hit send. Please note during the presentation, all of the phone lines will be muted to cut down on background noise. We will not be taking any questions over the phone today. You will have to submit those using the web portal. With that introduction, I'd like to turn the program over to Michelle.
And thank you, Dennis. Good morning and good afternoon to our participants. Susan and I are really pleased to have this opportunity to share with you ISMP's work to identify and address these common unsafe practices and also at-risk behaviors that are associated with the preparation and administration of IV push medications. And we think this work is particularly important as these risks may not be well recognized by frontline nurses and perhaps to some extent to nurse managers and nurse educators. So I'm going to lead off our program with an overview of the various safety challenges that have been associated with IV push medications, and Susan will specifically highlight our guidelines. There we go. Okay, so to give you some context for this work, we looked at error reports concerning IV push medications submitted to the ISMP National Medication Errors Reporting Program. Also, our clinical observations that we have the opportunity to make during ISMP proactive medication safety risk assessments have really been helpful as well. In our work with hospitals, we often have the opportunity to observe medication preparation and administration and to interact with frontline nurses. It sure does give us specific insight into current clinical practice and the various reasons why frontline staff may be making particular choices. We also receive practice questions daily through the ISMP website, which again gives us a unique insight. And several ISMP surveys that have been published in the ISMP Medication Safety Alert have provided great information. In 2010, we had more than 800 participants respond to a survey regarding the impact of the U.S. economic crisis on medication safety. A second ISMP survey in 2012 reviewed the practice of over 500 nurses when using a cartridge-type syringe, such as Carpuject. This was initially designed to look at practices around syringe overfill, but the survey really uncovered that many nurses were not concerned with overfill because of the way they were using these medication cartridges, which we'll talk about. And then the 2014 survey, we were delighted. We had such a great response. We had over 1,700 practitioners that were responding, gave us great insight into the often disparate and risky practices concerning dilution. Then our most recent survey in 2018, that was in response to these previous three. We wanted to do a pulse check and get a sense of how practices were at this point in time. And again, we'll discuss that, and we still see the opportunity to impact some of these risk-prone processes. And then, of course, we did a literature review. So we recognize that IV medications are an essential component of care, and they provide great clinical advantage. That's because of their immediate therapeutic effect and their ability to support plasma drug levels to reach an early target. But at the same time, and for much the same reasons, harm can easily result from IV drug administration because of the immediate bioavailability of these IV-administered drugs, the narrow therapeutic range of many of them, as well as the limited ability to reverse systemic effects once that IV push medication is given. Because of the propensity towards serious harm, certain IV medications have been designated as high alert medications by ISMP. And what we mean by that is high alert medications have a narrow margin of safety, and errors with these drugs are associated with a much greater risk of patient injury or death. So although we know that the literature contains many reports about the types, the causes of IV medication errors, there really are relatively few studies that give us a detailed analysis concerning the incidence, the severity, and proximate causes of IV medication administration errors. So in a 2007 study by the American Nurses Association, this was looking at injectable medication errors. 99% of the nurse participants, there were over 1,000 respondents, believed that the risk to patients was serious if errors did occur in their use, and that almost half the errors were likely to happen during preparation and administration. Errors such as failure to check patient identification, administering the wrong rate were identified and categorized. Now, despite its status as an effective method for administering medications, injection-based drug administration really does pose risk for many reasons: the complexity of the process, the multiple steps that are often required to prepare, to be able to measure and administer these medications over certain time intervals. Studies that have really looked on injectable medication errors do confirm their high rate of occurrence, with an incident rate that far exceeds errors with non-injectable medications. For example, here we have a systematic review and a meta-analysis of 9 published studies, and that determined an overall 73% probability of making at least one clinical error with these IV medications. And then in a study by Westbrook, this was looking at errors in the administration of IV medications in a hospital. The results there indicated that a quarter of the errors would likely result in permanent harm. So certainly very compelling. And what we do know within the limited published literature is that administering IV medications too quickly is the most common type of IV medication error. And these studies indicated that in anywhere from 43% to 69% of these IV push dose administrations that were given too quickly, these were clinically significant. There was a wide variability in the rates of administration in these studies. It certainly matches what we see in our work with practitioners in hospitals. IV push medications may often require slow administration over 2 to 5 minutes. So giving IV medications too fast may cause patient discomfort, phlebitis, and other complications. So in this next slide, we sure heard about a case that led to a patient's death. Here, an ED physician prescribed labetalol 20 milligrams IV push. This was a patient experiencing a hypertensive crisis. The nurse retrieved the medication quickly. The patient, though, was already in the process of being transported to radiology. So the nurse was rushing. On the way, the nurse administered the medication in a matter of seconds. The patient immediately became unresponsive and was not able to be resuscitated. To the organization's credit, they actually discovered several other cases where rapid IV push of labetalol may have contributed to other patient harm. Another potential source of risk is simply the intended meaning of the term bolus, which is used to describe a small amount of IV medication over a short time to elicit response or provide a loading dose. But we've found that it's been misunderstood to mean very quick IV push instead of administration over a short interval. So think in your own organizations, are these terms interchanged? And when we consider the rate of IV push administration, really 2 to 5 minutes can be a long time to give a single medication. And we recognize that clocks showing the elapsed time do improve practice. It's interesting that we find staff administering IV push medications at times without a watch or a nearby digital clock. So tough to be able to do that accurately without that. And using the tubing and the ports that connect closest to the bloodstream for administration is optimal to avoid leaving medication in the dead space of IV tubing. So as I mentioned, we recognize that research shows that the incidence of errors with injectable medications is definitely higher than other forms of medication. And there's really multiple factors that can increase the risk of errors and patient harm with these injectable medications. They include using part of a vial or ampule, or more than one vial or ampule for a single dose. And how often does that happen in practice, of course? Also with the multiple steps of manipulation that are required to prepare the drug, such as vial to syringe or syringe to syringe transfer. Dilution is another one, or use of a filter. A reconstitution of a medication on a unit for IV push administration that needs to use a specific diluent. And then having concentrated injectable medications where there may be further dilution required. So the purpose of our 2014 survey was to learn more about these dilution practices before IV push medication administration. So this survey, as I mentioned, we had almost 1,800 respondents. 97% were registered nurses. And the survey results suggested that nurses frequently dilute medications. Now, this practice may be necessary depending on the drug, but also one that may unnecessarily result in repackaging of pre-filled syringes or other containers that are provided by the pharmacy. We find that we're at a setup then for unlabeled or perhaps mislabeled syringes, contamination in the transferring of a dose, and also the potential for losing some of the volume or other dosing errors. Over 83% of the nurses who did respond reported that they further dilute certain IV push medications, and that would be at a rate of sometimes, often, or always. And pertaining to the containers in which these medications were provided, those available in single-dose vials or ampules were often diluted. You can see here on the slide 77%, and then 14% of which the nurses responded always doing that. And even when the pharmacy dispenses a pre-filled syringe that could contain the patient's specific dose, as many as 20% or more respondents further dilute these medications. So we really do see that further dilution of these adult IV push medications is quite common on the patient care unit. Now, in the 2018 survey, overall, 84% of participants reported that they further diluted adult IV push medications. And these findings are similar to the 2014 survey. We were at 83% there. But the good news was that they were doing this less frequently. So looking at that single-dose vial or ampule, the response in the 2018 survey was at 59%, sometimes, always, or often dilute single-dose vials or ampules. So definitely a change there. And when asked about the dilution of the specific drugs, what was happening was opioids, anti-anxiety, and antipsychotic medications were those that were more frequently being diluted. Now, some of the primary factors that influenced the decision to further dilute these adult IV push medications, the primary factor was associated with the desire to give the drug slowly. You can see 94% of those answering that was one of the reasons. The second reason was to avoid patient discomfort. That was about 70%. Reducing the risk of extravasation was about a third. We definitely had some other reasons in our 2014 survey that may not be clinically necessary. To tell you a couple, several respondents suggested it must be just safer to dilute all medications before IV push. That was their practice, so that they would be able to administer them slowly and enable monitoring easier. Others felt that there was just no way to understand how the patient was going to respond, was it going to hurt, so it was just best to dilute all medications. And other respondents told us that they just simply hang a piggyback of normal saline so they can administer concurrently with an IV push medication, thus getting around the dilution in their mind, a practice that may not be appropriate without a prescriber's order. Now, for those who dilute medications, the 2014 survey asked respondents whether they use the standard volume of diluent each time that they're going to dilute a specific medication. So what we found out was the response was nearly split, just a little less than half, about 49%, indicating that the volume of diluent that they chose could be variable, even for the same medication. Respondents were also asked to tell us how they determined the volume of diluent to use. Again, we got a variety of responses. Most had personal formulas. For instance, using a milliliter per minute of time that was needed to administer the medication. So if an IV push medication needed to be pushed over 2 minutes, the medication was diluted in a total volume of 2 mLs and administered as 1 ml per minute. Certainly there were differences in approach if there was peripheral versus central line. And no respondents, interestingly, described a dilution process that would give a specific concentration. So I'm going to take 4 milliliters, for instance, of a diluent to 1 milliliter of drug, so I am getting a certain concentration per 5 mils. So as you would imagine, with this degree of variability, we had very few respondents reporting that they actually had organizational policies or guidelines on dilution. You can see 43% answered. that. Now, when dilution occurs, in our 2018 survey, we looked at this again. Most practitioners were using a saline flush syringe for this purpose. And we recognize this as an unsafe practice, and this appears to have increased since our 2014 survey, which at that time, 54% of practitioners said that they were diluting medications using a saline flush syringe. Now, one possible reason for the increase may be the shortage of vials of 0.9% sodium chloride at the time of the survey. Many of the practitioners did note that in the comments section. So you can see here approximately 56% said they were using the flush syringe to dilute medications at least half the time, and 19% that they always do this. So think about your own organization. Is this a practice that may be in place there? Unfortunately, when describing this, most participants did not include that they were relabeling the flush syringe. So more than a quarter of survey respondents reported that they rarely or never label IV push medications that have been prepared away from the bedside. Now, in terms of reconstitution, there are relatively few medications that do require reconstitution or dilution right before administration. But studies on errors that occur at this point of parenteral medication preparation do suggest that significant numbers of IV medication errors, up to 49%, involve the reconstitution process. So we were sort of surprised at that. We did not recognize the degree of risk of error with reconstitution. So, for example, some of the studies indicated from anywhere from 11% to 49% of medications being diluted with the wrong diluent. That could lead to wrong stability, solubility, and then maybe precipitation or particulates in the preparation. ISMP has received multiple error reports where a medication that requires reconstitution with its own specific diluent that is sent with the vial of the powdered medication, that the errors that we've seen is that just the diluent may be given instead of using it to reconstitute the medication. And then also reconstituted medications are often drawn back into the syringe containing the diluent. So then this can tee you up for an unlabeled or mislabeled syringe. So how much nurse preparation of these IV push medications is being done in the patient care area? How about, in your practices? We, in our 2010 survey, had a response that 25% of nurses said that they're mixing more drugs than ever before in the clinical unit. Now, of course, this was the survey that was looking at the impact of the economic downturn on medication safety. And this all was in the milieu of Joint Commission standards to dispense in the most ready-to-use form. We recognize that this finding was likely impacted by highly decentralized drug distribution, the wide use of automated dispensing cabinets with more medications being stored in these cabinets, perhaps contributing to a greater need for some nurse preparation after withdrawal from the cabinet. And most participants in our recent survey indicated that they don't receive IV push medications in ready-to-administer syringe. So thus, they're preparing these medications prior to administration. And this has become more common during the ongoing drug shortage crises. So in our work to promote safe practices around IV push medication use, we sure have learned that there are instances of limited awareness of at-risk practices. I wanted to share with you some of the mistaken beliefs, which include the reuse of single-dose vials in an individual's mind may depend on just the vial size. So a larger volume may falsely indicate to a practitioner that is suitable for reuse. Reentry into a multiple dose vial was not viewed as a problem in some cases because staff were believing that any pathogen from the syringe or the needle would be intercepted because of the bacteriostatic or preservative agents. So we know common preservatives used in these multi-dose vials may be bacteriostatic, but they're not going to destroy all bacteria and definitely don't have antiviral or antifungal activity. Another mistaken belief was that using a common IV bag was safe if discarded after 24 hours. They thought they were in a safe place. We find this in some of our consult engagements as well. So limiting use to 24 hours, doesn't prevent the risk of disease transmission. And then, boy, it would be scary if there was a contaminated solution that was being used for a large group of patients, perhaps on a floor. And then this next example about changing the needle will be sufficient. I can use the same syringe. Now this belief is definitely not just among nurses, and I'll share with you an example next. But we definitely have seen it in the use of insulin pens in hospitals and having multiple reported errors in which pens were used for more than one patient. And then back in a well-publicized outbreak in an outpatient endoscopy center years ago, we had propofol being used for sedation, and anesthesia providers were using the syringes to re-enter the vials. It was interesting, there was some recognition of the risk because they did change the needles on the syringes, but there was a misperception that contamination would be limited to the needle. And again, that would be a false understanding of risk there. So in these next two slides, let's take a look at some specific issues with cartridge type syringes. We did a survey looking at the overfill in cartridge X syringes back in 2012, and most nurses actually found were not concerned at all about the overfill because they were withdrawing doses from the cartridge using a syringe. Input from these nurses indicated that they didn't believe there was any risk because of their current practice, and they would use the cartridge like a single or multi-dose vial instead of the intended pre-filled syringe delivery system. So they were withdrawing all or part of the medication, and often unlabeled before administration. Now, in our recent 2018 survey, 2/3 of these respondents did also report withdrawing medications from a pre-filled syringe or cartridge and then putting it into another syringe to administer some or all of that dose. And 16% told us they were doing this more than half the time they encounter a pre-filled syringe. So it's very concerning. Now, potential safety issues with this type of practice certainly include the risk of contamination with entry into this cartridge that's not intended for puncture as a vial, and risk of contamination when using these single-use cartridges as a multi-dose vial. It sets us up with this kind of practice to have unlabeled or mislabeled syringes. And we also have the risk of a dosing or measurement error when we're doing the transfer from one syringe to another. The nice cartridge that has like a barcode on it, now we don't have this barcode on the new syringe that we're using. Certainly a risk of needle stick injuries and the potential for conditions that may facilitate drug diversion of products that have been documented as wasted. In the 2014 and 2018 surveys, nurses shed light on what are the factors that encourage them to do this. And most often they were citing the desire or their believed need to dilute medications before administration and the unavailability of syringe holders. Some of them didn't even know they existed, so that was pretty insightful, and that was actually fairly common. Also, we had comments that this is how I was taught. You can see here there's a variety of different statements that we received in this survey. Now, here are my last few slides. Let's look at concerns related to syringe labeling. That ANA survey that I had mentioned earlier of more than 1,000 nurses looked at the challenges of labeling syringes that contained injectable medications. And this survey revealed that more than 2/3 of respondents believe that errors could be reduced if they were more consistently labeling their syringes. About 44% of these nurses said they inject medications using a syringe more than 5 times each shift. and a third do it at least once. So if we can think of the number of nurses on a shift and multiply that by an average of these IV push medication doses that are prepared, and recognizing that, what do we say, that more than 2/3 of that time, or only half were labeling them, that would be the potential for quite a number of syringes without labels that could get us into trouble. Now, in the 2018 ISMP survey, responses largely indicated that labels on these clinician-prepared syringes are likely to be limited or, in fact, absent. Only half of our participants told us that they always label IV push medications that they're preparing. And comments suggested that labeling was sometimes accomplished by taping the vial to the syringe. And also, lastly, more than a quarter, about 28%, said that they rarely or never label syringes. So certainly that gets our attention. An event that we talk about was one here with a syringe that was not labeled and contained vecuronium. It was prepared for a trauma patient, so you can get the scene at that time. But this medication wasn't used, and unfortunately, the syringe was set down near a supply of saline flushes and accidentally was picked up and used to flush the line of an alert toddler. This child became flaccid, stopped breathing. Fortunately, she was in the ED and was able to be intubated and ventilated, so permanent harm was averted. But certainly pretty compelling patient harm related to simply an unlabeled syringe. And now on my last slide, let's just take a look at some of the reasons in our recent survey of why these syringes are not getting labeled. Participants who are not labeling syringes that they prepared away from the bedside were mainly because they felt it was not necessary if only one medication was being prepared. You can see 51%, or if one syringe is being prepared, certainly emergency cases. But surprisingly, 7% of participants said they could even distinguish between several syringes that did not have labels by their visual appearance, or the size of the syringes, the contents, the needle cap changes in color. So it certainly made us nervous when we heard about these kinds of methods for distinguishing unlabeled syringes. So with that, let me turn it over to Sue.
Okay. Well, thank you, Michelle, for giving us a clear understanding of the often unappreciated risks that are prevalent with IV push medication use. ISMP continues to make it a priority to better understand these risks and to share best practices in an attempt to address these issues. The work behind the ISMP Safe Practice Guidelines for Adult IV Push Medication started back in 2014. ISMP had held a 2-day national summit with expert practitioners from around the country, and after review of the IV push survey results, the current literature, and related ERR reports, participants shared their firsthand experiences about the challenges of IV push use. The outcome from the summit was a set of consensus recommendations that you can see pictured here, and they were published in 2015. This reference is readily available at no charge on the ISMP website in the Guidelines section at the link provided here. With this set of guidelines, there are 31 individual statements divided into 8 categories, each addressing key risks identified at the National Summit. Unfortunately, we will not have time today to review all of the categories and statements, but over the next 20 minutes, I'd like to highlight for you those recommendations that are most significant in attempts to reduce risk. Now, you may wonder why the initial safety strategy in this document focuses on medication acquisition and distribution. But just to be clear, this guidance was written for all stakeholders in the medication use process, which have an impact on safe IV push medication use. So one of the most important things that organizations, and especially pharmacists, can do to support the safe practice is to provide IV push medications in a ready-to-administer form as much as possible. Meaning, these products are either purchased in commercially available IV push forms or dispensed in ready-to-administer syringes that have been prepared by the pharmacy. And now, as Michelle mentioned, these medication errors associated with the administration of wrong dose or concentration are more prevalent when frontline practitioners are provided with a product that requires additional manipulation. So when nurses have to either reconstitute, dilute, or measure partial doses at the bedside. In one study of medication administration errors, 4 error types, wrong diluent mixture, wrong diluent volume, wrong bolus rate, and drug incompatibility accounted for over 91% of the errors, and 27% of these were considered serious. This strategy is actually not new, but was first described as a priority practice over a decade ago in a joint summit that was attended by ISMP and included practitioners from the American Society of Health System Pharmacists, the United States Pharmacopoeia, the Infusion Nurses Society, the Joint Commission, and the National Patient Safety Foundation. The use of commercially available pre-filled syringes or pharmacy-prepared syringes as compared to routine provider-prepared syringes has also been endorsed by a safer practice by the Anesthesia Patient Safety Foundation since 2010. So again, not a new practice. For a number of reasons, some healthcare personnel are unaware or do not understand and do not adhere to what are considered basic principles of infection control and aseptic technique when preparing IV push medications or flush syringes. This has led to unnecessary vial contamination of flush products and public health outbreaks of infectious diseases such as hepatitis B and C. So in support of the Safe Injection Practices initiatives by the CDC, this second strategy indicates that practitioners should primarily use a commercially available or pharmacy-prepared syringe of appropriate IV solution to flush and lock vascular access devices. And like the previous recommendation, this is really intended just to reduce the potential for product, syringe, or needle contamination caused by unnecessary manipulation outside of the pharmacy. So in instances when commercially available pre-filled flush syringes are unavailable, such as during a shortage, the CDC recommends the proper use of single-dose vials over multi-dose vials for this use. Recommendation 3.2 suggests that IV push medication should only be diluted when recommended by the manufacturer, supported in peer review evidence, or in accordance with approved institutional guidelines. Dilution of certain medications may be required by the manufacturer, and whenever possible, this should occur in the pharmacy before dispensing the medication. Unnecessary dilution, especially the dilution of ready-to-administer products, adds complexity to the drug administration process and introduces the needless risk of medication error and contamination of sterile IV medications and solutions. It is no longer appropriate for practitioners to automatically dilute all IV push medications and in any manner they choose. Expectations for standardization, reliable practice should be established. 3.3 speaks to that if dilution and reconstitution of an IV push medication is necessary outside of the pharmacy, that practitioners perform these tasks immediately prior to administration in a clean, uncluttered, and functionally separate area, using organization-approved and readily available drug information resources and sterile equipment and supplies. So the use of a dedicated workspace is considered essential to maintain asepsis when IV push medications are prepared for immediate use outside of the pharmacy. Professionals in infection control suggest that in addition to a clean and dry workspace, parenteral medication preparation must be performed away from obvious contamination sources such as waters and sinks. Additional preparation of immediate use syringes or IV infusion the night before, and sometimes even just hours before use, is considered by many a controversial issue, but be clear that this practice is not supported by APIC, USP, the Infusion Nurses Society, or ISMP. Now, I share these next images with you as often these are the common places that we see IV push medication preparation occurring: on top of the automated dispensing cabinet, or at the workstation on wheels, on top of keyboard, and even at the desk, in the corner of the desk at a busy nurse's station, and obviously not in a clean, uncluttered, and functionally separate location. So let's face it, we can do better. Procedures should be developed and locations identified where such critical work should occur if it's necessary. In the event that reconstitution or dilution of a medication is necessary on the clinical unit, organizations need to provide ready access to the proper diluent and instructions for reconstitution or dilution to support safe practice. In some facilities, this can consist of a pharmacy-prepared kit where the drug and diluent and instructions for use may be housed together. While in other facilities, this information is readily available for the nurse directly on the medication administration record. Over the years, nurses have adopted an unsafe practice of using carpet-jects as well as other pre-filtering cartridges as single-dose or multi-dose vials by withdrawing the medication from the cartridge. While not economical, more importantly, this unsafe practice has also been known to contribute to dosing errors, drug mix-ups, product contamination, and other types of medication errors. The newly prepared syringes are often unlabeled and do not contain the barcode, as Michelle mentioned. Resolution of this issue is often multifactorial. We need to make sure that staff understand this risk and make sure that syringe cartridge holders are readily available when needed. And charge nurses and other leaders need to coach any at-risk behaviors that are observed. The next recommendation may come to some of you as a surprise. This statement requires that clinicians do not dilute or reconstitute IV push medications in a commercially available pre-filled syringe of 0.9% sodium chloride. And here's why. Commercially available syringes of saline and heparin are regulated by the U.S. Food and Drug Administration as devices and not as medications. These devices have only been approved for the flushing of vascular access devices and have not been approved for the reconstitution, dilution, and or subsequent administration of IV push medications. Pre-filled flush syringes have not been tested for product safety when used in this manner. So some manufacturers of these products have attempted to limit the use of their pre-filled syringes in this way by placing a warning on the syringe barrels that may state IV flush only. Some manufacturers have also limited or removed the gradation markings on the flush syringes to prevent measurement of the secondary medication into the syringe. Remember, when the pre-filled syringes are used in an off-label manner, the practitioner and employer bear the legal liability for any adverse events that occur from this practice. The mislabeling that occurs when medications are added to a pre-filled syringe like this creates significant risk for an error. When another medication is added to a flush syringe, there's no adequate method to amend the manufacturer's label without covering the current information. Thus, the syringe frequently remains unlabeled as 0.9% sodium chloride, and you can imagine then how easy it is to mix that up as a flush administration. Because this unsafe practice itself has gone unchecked for a number of years, it has led to many of us mistakenly believing that the risk of the error is really insignificant. But I can tell you now that many organizations are aware of this risk of mislabeled syringes, wrong doses, and the potential breaks in aseptic technique, and have made it a priority to change the bedside practitioner's understanding of this risk and to ultimately eliminate the use of this vehicle for dilution and reconstitution. The last one in this section under Clinician Preparation, and to be congruent with APIC and CDC guidelines, 3.8 recommends that we're never to use IV solutions in containers that are intended for infusion, including mini bags, as a common source container to prepare IV flush syringes or to dilute and reconstitute medications for one or more patients in the clinical area. IV infusion bags are labeled by the manufacturer as a single-dose container, and as such are intended for administration as a single dose for use promptly after the container is opened, and any unused portions should be discarded. Examples can be found in the literature, as Michelle mentioned, of the common source infusion bags resulting in the administration of a contaminated injection solution. This is a significant risk because if dilution becomes contaminated, the impact of disease transmission impacts a large group of patients. Respondents to an earlier ISMP survey erroneously suggested that this was okay, this was a safe practice because they labeled this bag and they discarded it after 24 hours. However, recognize that just because we limit the use of these containers to 24 hours does not prevent the disease transmission if that bag were to become contaminated. The next section has to do with labeling, and we know that medications or solutions in unlabeled syringes are unidentifiable and have been mistaken for different medications or solutions and administered to the wrong patient in the wrong dose and by the wrong route. Many errors associated with unlabeled containers have resulted in serious patient harm and even death. It is not safe to prepare a medication away from the patient's bedside and carry it to the patient unlabeled, even if the intent is to administer it immediately. Clinicians have been unexpectedly interrupted and distracted while carrying an unlabeled syringe to the bedside, thus prone to a mix-up. Thus, the recommendation is to appropriately label all clinician-prepared syringes for IV push use unless prepared at the bedside without an immediate break in the process, meaning that the nurse prepares the medication and administers it to the patient without it leaving his or her hand. So in terms of labeling, let's be clear. Medications in identified syringes should never be used if they are not labeled. Group consensus at the summit determined that completing an entire sequence of preparing, scanning, and administering a drug for IV push injection prior to preparation of a second medication will help to limit the possibility due to syringe swap. But if you are going to prepare more than one syringe at a time, then completing the entire sequencing of preparation and labeling of one syringe at a time is the safer approach. Alternatively, if the preparation is occurring away from the bedside, immediately label each syringe one at a time before preparing the next medication or solution. And only bring one patient's labeled syringe to the bedside for administration and avoid the shortcut of trying to carry more than one patient's syringe down the hallway at a time. We also want to make sure that since more than 50% of practitioners are not labeling syringes regularly, that pharmacy can help to support this process by providing pre-printed, ready-to-apply labels with the drugs, including available sterilized labels as needed. Lastly, practitioners are asked to never pre-label empty syringes in anticipation of use, as the wrong medication or solution in the past has been drawn into a pre-labeled syringe. Rates for IV push medication administration listed on drug information resources as slow or fast are ambiguous terms and should be clarified. Depending on the medication, the speed at which the practitioner administers a dose can make a therapeutic difference or may contribute to an adverse reaction. So during our assessment of this problem, we noticed that many practitioners are faced with having to decide themselves how fast to push a medication, which also may be impacted by the volume of diluent that they choose to use. Nurses reported that they have their own algorithm by which they administer IV push medications and any subsequent IV flush. Ideally, we think this work needs to be standardized and not variable between practitioners. Medications should be administered at the rate recommended by the manufacturer, supported in evidence and peer-reviewed literature, or in accordance with improved institutional guidelines. And after administration, use an appropriate volume of the IV flush to ensure that the entire drug dose has been administered at the time recorded. Now, keep in mind the rate and the volume of that subsequent flush can also result in unintended rapid or delayed administration of the drug. Any medication left in tubing or catheters dead space will be flushed into the vascular system at the same rate that the flush or associated compatible solution is being administered. Please make sure this concept is well understood by all practitioners. With thousands of prescription medications available in the U.S., frontline practitioners can definitely be overwhelmed with trying to know and learn whether or not it's acceptable to administer or not a medication through the IV push method, or to learn the safe rate of administration. And while most organizations use online drug information resources, ISMP has determined that within many of these resources, instructions regarding drug dilution and IV push administration procedures, including the rate of administration, may be lacking, or ambiguous, difficult to find, or variable even between resources, all resulting in unreliable practice. Package inserts sometimes will have this information, but often the package insert remains in the pharmacy and is rarely available to the frontline provider. In many cases, organizations have determined that not all IV push medications may be approved in all practice locations or to be given by all clinician types. So ideally, we suggest that organizations create readily available point-of-care guidance documents for IV push medication use, and either have that information provided on the MAR or again in the supplement document. Clarifying procedures by creating this drug-specific guidance document helps to establish expectations for care for particular units and for particular care types. And clinical pharmacists working in conjunction with nurses can really be an invaluable resource to help inform the content of this tool. So while the basics of IV therapy are often taught within accredited nursing programs and other professional schools, the curriculum is variable and we know often does not require or even allow the student to practice IV push administration as part of their clinical rotation or simulated learning. We know from recent ISMP surveys that nurses and other practitioners may learn IV push procedures on the job, either firsthand through a preceptor or possibly through a course to confirm venipuncture competency. But because a nationally approved curriculum does not exist, we recognize there are a wide range of practices, many of which are unsafe, but often are unrecognized by those who use them and who teach them to new staff. So we really strongly believe that competency validation should occur for all practitioners, regardless of profession, who are required to safely perform IV push medication administration as part of their role. So it is clear as we work with organizations across this country, there is still much to be done to change attitudes and beliefs and the conditions for safe preparation and administration of IV push medications. There's still a need to create an awareness and a recognition of an understanding of the risk and thus the need to alter current practice. We need to make sure we're convincing professional staff that the efficiencies gained in the workarounds that they use are not without risk. Just because they've always done it a certain way and nothing bad has ever happened is not a reason to continue a risky practice. We also need to begin to change behaviors, making it easy to do the right thing, such as providing more medications in a ready-to-administer form to avoid that unnecessary bedside manipulation that is so common, moving away from using those pre-filled syringes of flush solution for drug dilution, reconstitution, and administration, limiting dilution to only those that we know is based on evidence, and using organizationally defined processes and resources when we have to do that dilution, and providing easy-to-use labels at the point of care. Even from our recent surveys, it was clear that many nurses are unaware of the current variation in practices between units and even between practitioners on their own unit, their same unit. But we know that these risky behaviors occur every day across this country. And we believe that understanding current practice at your local level is the first step towards addressing gaps in our practice in our profession. So with harmful outcomes at stake, ISMP believes it's essential to provide practitioners with a useful tool to help them in identifying and managing targeted risk with IV push medication use. So earlier this year, we released a gap analysis tool, which is pictured here, to heighten healthcare practitioners' awareness of those safe practices and assist with identifying and prioritizing opportunities for improvement. The online resource allows organizations to evaluate their practice and is available at no charge on the ISMP website at the link provided here. And online submission of responses are being accepted through April 30th of this year. This 50-item tool asks organizations to rate the adoption of ISMP safe practices using a 4-point scale, and each organization will receive a score upon online completion. Once the data set is closed, an aggregate national comparative data will be provided so participating facilities can compare themselves to like facilities. Now, we are hoping to have good participation on this project, and if there's anything that you've been concerned about after hearing today's presentation, we encourage you to use this tool to assess your current practice and to drive safety improvements. We know that the challenges of improving the safety of IV push medication use do not belong only to the frontline provider or to the bedside nurse, but rather to a variety of stakeholders in healthcare, including manufacturers, regulators, academicians, and professional organizations, as well as individual organizations that must adopt and operationalize these best practices. ISMP has a role too. We will continue to work with all of these stakeholders to accomplish IV push medication safety goals. Please share these guidelines with others, and let's continue to make safe practice a priority. Dennis?
Thank you, Michelle and Susan, for that excellent presentation. Now we're going to enter the Q&A portion of our webinar. And just a reminder to submit a question. You can do so by under the tab marked questions. You can type in your computer and go ahead and hit send. We actually have a number of questions, so we'll go ahead and get started, and we'll try to get through as many as we can. We actually had a few questions related to, is there a plan to provide guidelines for IV push in children?
So Dennis, I will take this one. When we did have our summit, we recognized there was probably additional complexity in measuring and the need for dilution of small volume medications, and recognized it probably wasn't within the scope of that work because we wouldn't have enough time to delve into those nuances. So these guidelines are for adults, of course. We do think that they are applicable to pediatrics, but we currently don't have time set up to delve into another summit, but we would encourage practitioners that are caring for pediatric patients to look at these guidelines because we believe they're really universal.
All right. Excellent. There's a statement here, and I might want to get your commentary on this statement. Purchasing pre-filled, ready-to-administer syringes is a waste of money since most nurses practice dilution prior to the administration of IV push medications. What are your thoughts around that statement?
I think that's a fair pushback, but what our work is to turn that around, is to really help practitioners see the risk with dilution. And on their behalf, many references and practices that are taught are to dilute, and we find that pretty universally. So our challenges ahead of us is to help nurses recognize that they're in a much safer place when they have a pharmacy-prepared or commercially available patient-specific dose in a syringe. Mm-hmm. So that's our challenge. I agree.
Mm-hmm. Mm-hmm. Could you comment on best practices for the administration of IV push, such as manual administration versus the use of a device such as an infusion pump?
So I think I'm wondering if this question is getting at would we believe that IV syringe doses could be safer if administered on an infusion pump. I'm not sure if that may be the intent of the question. And we actually had that in the document as further inquiry. I think that also is so complicated too with our current drug shortages. In fact, nurses are telling us that because of that, they actually may be receiving medications in a form that they do have to do more preparation and pull up from a vial. So, Dennis, you probably have a comment about that yourself.
Yeah, I think it's definitely a great question. I think, when we talk about something that's slow IV push, like you had on your slides, 2 to 5 minutes, that's a long time. And I feel more comfortable leveraging technology to give that medicine over a period of time continuously rather than giving small increments. So I think if you have that infrastructure there and that technology, I think it's important to leverage it, especially depending on the situation and the medicine being infused. So I think that's Mm-hmm.
I agree, and I think what comes up in the world of pediatrics is that nurses are probably more in a position to be able to give syringe doses through their syringe pump that they have, because it's such a common way of administering medications to children and neonates. We wish we would have been able to delve into that, because that actually was on our pre-summit list of questions, but we did not get to tackle that one. But thanks for your input too, Dennis.
Sure. All right, we'll go to the next question. Is there a recommendation or a good guide for reference regarding the need for dilution and rate of IV push for a medication?
Yeah, that is so variable, and that has always been our challenge. We were so surprised when we started to look at this problem of how variable the resources were. Some of it is the ambiguity of the language that's used. They might not even give time increments. They make it slow. And it's really up to organizations to establish what they want to do based on the evidence they can find. Certainly using the drug package inserts as much as possible that will primarily have the information that might be needed around some of that timing. But again, as I mentioned, sometimes that information just is absent. So as we continue to look at this problem and look at what medications we absolutely have to give IV push, we should be looking again towards that evidence and whether that is established in the literature or something that we may need to refer to our clinical pharmacists to gain help with and look in their literature to see if we can find that information. But it's a tough one to tackle. Organizations, want to do it correctly, and I think they probably tend to err on the side of giving more slowly than probably they absolutely have to. And when I mean by that, usually people say 3 to 5 minutes is what we consider slow IV push. But most organizations have started now to define what they mean by that, just so everyone is doing it the same way.
Great. We're going to go through prepare for 1 or 2 more questions, but before I do, I've got a few questions asking about being able to get a copy of the slides and maybe seeing this webinar again. So just to let folks know, this webinar will be available on the ISMP website starting tomorrow. So you'll be able to get a copy of the slides. You should also get a copy of the slides through the handout section of the webinar tool, but we're going to be posting this tomorrow. So the next question is, can you describe or elaborate around the use of the pre-filled syringe as a device and for it not to be used as a medication delivery device? So I'm thinking they're maybe talking about the flush syringes, which seems to be a common problem these days.
So again, these flush syringes are approved by the FDA as a device. So they're not approved for medication dilution, reconstitution, and administration. It totally doesn't go through the same approval process as a medication would through the FDA. And because of that, the use of that in that manner, using it for medication administration, there's no studies to show its safety and efficacy through it, and sterility. So that is why the consensus at the summit was very clear that there is nothing to say that this is a safe practice. And although it is very efficient for nurses, and we recognize that wholly, it is just not something that we could clearly recommend because the evidence is just not there to support its safe use.
And I think what this question really has come up quite a number of times. And another issue that may be related is in their use as devices, what we're going to do is push out the flush solution. So the syringe is not intended for pulling back into it. So the fluid path going forward is sterile, but not every manufacturer may necessarily indicate that if back that the syringe barrel would be sterile. So it's hard to know that, and so that's another issue that would lend itself to using it for its intended purpose.
Right. And I think the other part to that really has drawn our attention to it was just the fact that we saw errors related to nurses using these syringes that were labeled as 0.9% sodium chloride and having a medication in them, but they were not then relabeled. And so then this misuse of these syringes was so common. It's just so many risks associated with this practice that we need to look for better alternatives.
Great. Well, thank you, Michelle and Susan. We actually got an overwhelming number of questions, so we went through as many as we could. Unfortunately, we can't get to every question that was submitted, but the number of questions and the number of folks on today's call just shows how important this is a topic and out there in the current healthcare. And we need to keep talking about it because we want these practices to be safe. So now that our allotted time has come to an end, I'd just like to thank Michelle and Susan again for taking the time and sharing their expertise on this topic. You guys did a great job. And thank you, everybody, for tuning into the webinar. Without you, we really can't have these kind of topics. So like I mentioned earlier, a recording of this webinar will be available on the ISMP website, along with a copy of the slide set. And at this time, this concludes the webinar for today. Please enjoy the rest of your day. Thank you.